Hey, future nurses. It's your pal from Book Podcaster, dropping in to arm you with some serious brain power.
Think of this as your study buddy.
Exactly. Your study buddy that's already cracked the code on some really complex stuff. We know you're tackling a mountain clinicals, late nights, questionable coffee.
Oh, we've definitely been there.
Right. So today, we're diving deep into something that can feel a bit, well, intimidating. Schizophrenia and other psychotic disorders.
But don't sweat it. We're going to break it all down.
Step by step. Ready to unlock some crucial insights. Maybe have an aha moment.
Absolutely. And look, this isn't just about memorizing terms from a textbook.
No way.
It's about really understanding the core of these conditions so you can give the absolute best care.
So our mission today.
We'll explore what really defines the schizophrenia spectrum and other psychotic disorders. We'll look at the different pieces of the puzzle, potential causes, how they impact people.
And the big one, your role as nurses.
Exactly. Your incredibly vital role in supporting these patients.
Okay, so schizophrenia spectrum disorders. That sounds, well, complex. Where do we even start? What are the key things we need to wrap our heads around?
Okay, so at its heart, schizophrenia, thinking about the Townsend definition here, it's a significant mental health condition. It's marked by some core features.
Like what?
Things like disruptions in thinking, a really altered perception of reality, difficulties managing emotions, and often a tendency towards social withdrawal.
Can you give us an example, something to make it a bit more real?
Sure. Let's imagine someone named Marcus. He's 24. Maybe he starts pulling away, isolating himself from friends, from family.
Yeah.
And he starts expressing these really intense worries, like a strong belief that the government is somehow monitoring his thoughts.
Oh, okay.
And when he tries to talk, his thoughts seem jumbled. It's hard to follow his train of thought. These kinds of experiences, after a thorough assessment, might lead to a diagnosis of schizophrenia.
That sounds incredibly difficult for him and for everyone around him. Now, you said spectrum disorders. Does that mean it's not just one thing?
Exactly right. Think of it as a group, a spectrum of related but distinct conditions. So besides schizophrenia itself,
There's more.
yes, there's schizoaffective disorder, brief psychotic disorder, schizophreniform disorder, delusional disorder, and even psychotic disorders triggered by substances or medications.
Okay, that's quite a list.
Yeah.
Can you maybe give us a quick idea of one of those others, like brief psychotic disorder?
Sure. Picture Tanya. She's 30. She goes through a really tough breakup, just devastating.
Right.
And shortly after, she starts hearing things that aren't their auditory hallucinations, maybe develop some strong belief that aren't based in reality, some delusions.
Okay.
But the key here is that these experiences are temporary. They last for, say, maybe a few weeks, less than a month, and then resolve. That situation might point towards brief psychotic disorder. The duration is a major differentiator.
Got it. So similar symptoms maybe, but the timeline makes it a different diagnosis. Now, the source also talks about phases, like a progression in schizophrenia.
Yeah.
Why is understanding those phases important?
It really helps to see how the illness can develop over time. Townsend describes 4 main phases. The first is the premorbid phase.
Premorbid, before the main illness.
Exactly. You might see really subtle signs, things you might only notice looking back. Maybe a slight decline in social interaction or school performance slipping a bit.
Kind of like early warning signs, almost.
You could think of it that way. Then comes the prodromal phase. This is where those subtle changes start becoming a bit more obvious.
Okay, what kind of things?
You might see increasing suspicion, more noticeable anxiety, maybe a slip in personal hygiene, things like that. It's a clearer shift.
Things are definitely starting to build then. What's next?
Phase 3 is the active psychotic phase. This is when the more well-known, pronounced symptoms really come to the forefront.
Like the hallucinations and delusions we hear about.
Precisely. Hallucinations, delusions, maybe disorganized speech. Those become very apparent during this phase. It's often when people first seek significant help.
Makes sense. And the final phase.
That's the residual phase. Here, the intensity of those active psychotic symptoms, the positive symptoms, generally lessens.
So things are better.
Often, yes, the positive symptoms improve. But what we call negative symptoms might persist or even become more prominent. Things like flat affect, that reduced emotional expression, or lack of motivation.
So it's not always a complete return to baseline. Can we track someone through these phases? Like an example.
Yeah, let's take one. Maybe in high school, his premorbid phase, teachers notice he's quieter, pulling back, grades dip slightly.
Okay.
Then prodromal phase, maybe early college, he becomes really suspicious of roommates, stops showering as often.
Uh-huh.
Then the active phase hits. He starts hearing voices telling him he's being watched, becomes very fearful.
Right.
After getting treatment, perhaps the voices become much quieter, less frequent, that's moving into the residual phase, but he might still seem emotionally flat, have trouble getting motivated for classes.
Okay, yeah, seeing that progression really helps illustrate it. Now, you mentioned positive and negative symptoms. That always sounds a bit confusing. Can you clear that up?
It does sound counterintuitive, doesn't it? But
Uh,
think of positive symptoms as things that are added to a person's experience, things that weren't there before.
Added. Like,
Yeah, hallucinations are a big one. Hearing voices, seeing things. Delusions, too, those fixed false beliefs. Like believing you have special powers, that's grandeur. Or believing someone is plotting against you, persecution.
okay,
Also, disorganized thinking, where speech might be hard to follow, jumps around. And sometimes unusual or bizarre behaviors, those are all positive.
got it. Things added on. So, negative symptoms must be
Things that are taken away or reduced from typical functioning.
taken away. Like what?
Avolition, that's a big one, a real lack of motivation or drive. Alogia, a reduction in the amount someone speaks. Poverty of speech. Anhedonia, the inability to feel pleasure from things they used to enjoy. And flat affect, that diminished emotional expression.
So, an absence of things we'd normally expect. Can someone have both?
Oh, absolutely. It's very common. Think about Desmond. He might be hearing voices commanding him that's positive,
Right.
but at the same time, he might show almost no facial emotion when talking and have zero interest in hanging out with friends. Those are negative symptoms. Both types really impact daily life.
Definitely. Okay, let's shift gears a bit. What causes these disorders? Is it just genetics?
It's complicated. It's almost certainly not just one thing. Genetics definitely play a part, a significant one.
How so?
While the risk is much higher if you have a first-degree relative, a parent, or sibling with the condition, that link is pretty well established.
Okay, so family history is a risk factor. What else?
There are biochemical factors, too. The dopamine hypothesis is probably the most famous one.
Dopamine, the neurotransmitter.
Yeah, the idea basically is that an overactivity of dopamine in certain brain pathways might contribute to psychotic symptoms. Now, it's more complex than just dopamine. Other neurotransmitters like serotonin and glutamate are likely involved too.
So, brain chemistry, anything else biological.
We sometimes see neuroanatomical differences on brain scans, things like slightly enlarged ventricles, the fluid-filled spaces, or maybe some reduction in brain volume in certain areas. But these aren't seen in everyone, and they aren't specific only to schizophrenia.
Interesting. So, brain structure and chemistry. What about outside factors, like stress or environment?
Yes, environmental factors are definitely part of the picture too. Things like significant early life trauma can increase risk.
Okay.
Substance use is another factor, particularly heavy cannabis use, especially during adolescence when the brain is still developing. That's a link we see more and more evidence for.
Cannabis, really?
Yeah, particularly high-potency cannabis used frequently during those critical developmental years. And even things like the stress of urban living have been suggested as potential contributors. It's likely an interplay genetic vulnerability interacting with these biological and environmental factors.
Wow, okay, so it's a mix. The source had an example, Liam. How does his story fit?
Liam's situation is a good illustration. He had a known family history. His twin brother had schizophrenia, so a strong genetic predisposition.
Right.
Then he started using marijuana heavily. And on top of that, he went through a really stressful breakup.
A lot hitting him at once.
Exactly. And then at 23, he started developing psychotic symptoms. It shows how that genetic risk, combined with stressors like substance use and a major life event, can kind of converge.
That makes a lot of sense.
Yeah.
Okay, so we've talked about what these disorders are, the symptoms, the causes. What about treatment? What helps?
Treatment usually involves a combination approach. Medication is a cornerstone, specifically antipsychotics.
Okay.
These help manage the psychotic symptoms, especially the positive ones. They're broadly grouped into typical or first generation, like haloperidol,
Right, I've heard of that.
and atypical or second generation, like risperidone or olanzapine.
What's the main difference between typical and atypical?
Both work on dopamine pathways, but atypicals often affect serotonin too and generally have a different side effect profile. They tend to have a lower risk for some of those really troubling movement-related side effects called extrapyramidal symptoms, or EPS.
Ah.
But, and this is crucial, all antipsychotics can have side effects. Things like significant weight gain, sedation, metabolic changes, and sometimes, though rarely, serious conditions like neuroleptic malignant syndrome and MS. So careful monitoring is absolutely key.
Managing side effects sounds like a huge part of nursing care then. What about beyond meds?
Oh, absolutely essential. Psychosocial interventions are vital for recovery and quality of life.
Like therapy.
Yes, individual therapy, group therapy, these help with coping skills, understanding the illness, processing experiences. Social skills training can be incredibly helpful too for improving interactions.
That makes sense, especially with the social withdrawal aspect.
Exactly. And family education is huge, helping families understand the illness, how to support their loved one, managing stress. That's critical. And therapies like cognitive behavioral therapy, CBT, can help people manage distressing thoughts or beliefs.
So it really takes a village, a whole team approach.
Hmm.
The source also mentioned a recovery-oriented approach. What's that about?
Yes. This is a really important shift in thinking. Instead of just focusing on eliminating symptoms.
Which might not even be fully possible.
Right. The recovery model focuses on helping the individual live a meaningful life despite the illness. It emphasizes things like function, independence, hope, finding purpose.
That sounds much more empowering.
It is. It's person-centered. What are their goals? What are their strengths? How can we support them in achieving what matters to them? It might involve peer support specialists, job coaching, things like that. It acknowledges recovery is a journey, not just a destination.
I love that perspective. Okay, bring it back to our listeners, the future nurses.
Mm-hmm.
What are the absolute must-knows, the key interventions when caring for someone with these conditions?
Number one, foundational. Establish trust. Your approach needs to be calm, non-threatening, consistent, and genuine. Patience is key. Really listen.
That therapeutic relationship is everything, isn't it? Especially if someone is feeling paranoid or mistrustful.
Absolutely crucial. Then assessment. You need to be comfortable assessing for hallucinations and delusions. Ask directly, but gently. Are you hearing things right now? Can you tell me about what you're thinking?
Okay, direct questions. What about responding to delusions? Do we argue?
No, definitely avoid arguing or directly challenging the belief. That usually just entrenches it or damages trust.
So what do we do?
You acknowledge the person's experience without validating the delusion itself. You might say something like, I understand that you believe the FBI is watching you. That must feel very frightening.
Okay.
Or, I don't hear the voices you're hearing, but I believe that they are very real and distressing for you. You're validating the feeling, the reality of their experience, not the content of the delusion. Gently offering reality orientation can sometimes help, but don't push it if it increases agitation.
Acknowledge the experience, not the content. That's a great takeaway. What else?
Promoting self-care is huge. Assisting with hygiene, encouraging structure in their day, medication reminders, and helping them develop social skills, maybe through group activities or role-playing.
Practical supportive actions.
Yes. And don't forget the family. Educating them about medication adherence, relapse prevention, providing support resources. That's a vital nursing role, too.
It really is a holistic approach.
Yeah.
The source had that case study, Naomi and Leo. Can you quickly walk us through that again?
Sure. Naomi's the nurse, Leo's 19, with paranoid schizophrenia. He believes the FBI is watching him via cameras.
Okay.
Naomi's approach is key. She stays calm. She acknowledges Leo's fear. That sounds really scary without saying, yes, the FBI is here.
Right, validating the emotion.
Exactly. She works on building that trust and relationship, consistently supports him with his medication, and gently encourages him to join structured activities like group session.
And did it help?
Yes, the example shows that over time, Leo started participating more in group and, importantly, began to express some doubt about his FBI belief. It shows how that consistent, empathetic nursing care can make a real difference.
That's such a powerful illustration of the impact nurses can have. Okay, as we wrap up this deep dive, what are the main points you really want future nurses to hold on to?
Look, these are complex conditions, no doubt about it. But understanding the basics, the definitions, the types, the phases, positive versus negative symptoms, the potential causes, the treatments, that knowledge is your foundation.
It gives you the tools.
Absolutely. And always, always prioritize that recovery-oriented, empathetic approach. See the person, not just the diagnosis.
All right, future lifesavers, you just took a major plunge into some heavy-duty info. Seriously, give yourselves a pat on the back.
You've absorbed a lot.
Totally. And remember, understanding this stuff isn't just about acing an exam, right? It's about truly connecting with your future patients, seeing them as whole people, and offering real meaningful support.
That human connection is key.
It might feel overwhelming sometimes, we get it. But you are building the exact knowledge and skills you need to make a profound difference. Keep asking questions, stay curious, lean on each other, lean on your instructors.
You're not alone in this.
Definitely not. You're on this incredible path. When it feels tough, just remember why you started. Take a breath, grab that probably not great coffee.
We won't judge.
We won't judge. And know you're doing great.
Yeah.
Seriously, you absolutely got this. And hey, final thought, remember to check in with yourself. You can't pour from an empty cup. Take care of you too.
And the thing back to Naomi and Leo, those small, consistent acts of skilled, compassionate care, they create ripples. They make a huge impact. Keep that front of mind as you keep learning and growing.